Data becomes powerful when it changes practice. Scientific Session 9, Make New Data Reality, focuses on translating emerging research into meaningful clinical impact. This session explores how new data is reshaping spine care, from representation and reporting of social factors in spine research to pressure monitoring in spinal cord injury. We'll examine advances in predicting failure in spine surgery, including the use of PROMs, AI, and advanced analytics, along with strategies to maximize patient survival in spine tumor surgery. The session also highlights new markers in myelopathy, bridging discovery from the lab to the spine clinic. Through expert insight and thoughtful discussion, this session turns evidence into action, continuing our mission of elevating the quality of spine care at the spine site.
Good morning, everyone. So I had the pleasure of coming to talk about something that I think is becoming more and more impactful in our everyday practice. I think when we think about the reporting of social factors in spine research, we really want to think about why does that matter? Ultimately, when we're interfacing with insurers, when we're trying to advocate for things that could help our patients overcome some of the individual challenges they have, we are so dependent on literature and data to interface with these large payers and even within our own institutions. And so when we are looking, as has been previously mentioned this morning, the most powerful data is going to be prospectively collected. Most of our outcomes measures are often retrospective reviews or systematic reviews. And while those things are helpful, I think this becomes a real opportunity for us to think about the inclusion of these social factors when we're designing our trials. So when we think about validity of research and how it can apply in our practice, we have to think about when these, incredibly powerful pieces of research are being published, who are we including? What are we balance elimination of these co-founding variables with the generalizability of these topics to our patient populations. And so, we're looking at why are we doing what we're doing? To whom are we doing it? And then the thing that really always comes to my mind is what are we not even publishing? What are we not collecting? And how does that impact our ability to understand what to do for these patients? So there was a really powerful analysis of this that was done in 2022, looking at the previous 10 years, randomized controlled trials published in our major journals, and a very small number of them reported race, ethnicity. And so I think that has obviously changed in the last 5 to 10 years. The data that exists now, what is obviously focusing more in that direction. But from an overview standpoint, when race was reported, 88% of the studies were performed in the U.S., and there was a major overrepresentation of white patients. When we use search and the topic I thought would be most relevant to the impact of social determinants of health, that was usually more of an urgent situation, is myelopathy. And so these are patients we're going to treat no matter who they are, where they come from, how they present, right? And so there were no results at that time. And so now I think there are attempts to use the major databases to answer some of these questions. But as has also been described numerous times during the meeting this week, the data that we have to put into AI, to these research studies, is the data we get out. And so when we look for things, we have these large inpatient sample databases, but we're restricted to the data that's already been collected. And so we can get ethnicity, number of levels fused, obesity, and there are comorbidity risks that are across studies replicated, where patients who were white versus black versus Hispanic had the predictable outcomes in terms of likely to be discharged home, length of stay. These are all things that are replicated across study over and over again. And so when we look at patients that have, when they're amalgamated into being stratified for any risk factor, whether it's race, education, or when we can use the area deprivation index and some of these other measurements of surrogacy for employment and health literacy, we still see that across studies there's an underrepresentation in race. Older patients have more risk factors, and that surprisingly, gender and BMI don't always make as much of a difference. So any risk factor was statistically significantly likely in these myelopathic patients to be associated with having a higher motor deficit at presentation, duration, despite these often being emergent cases, more likely to have a laminectomy infusion, meaning they might have more multi-level disease, higher baseline pain scores, longer length of stay, and non-routine discharge. So at the 24-month MCID PRO, they were also less likely to have achieved that meaningful difference. And so what I would just like to leave us all with is that, there are a few studies that in the, interim since that large meta-analysis were published that I thought really did an amazing job of moving this forward. Godzik did a systematic review last year where he talked about looking at the area deprivation index in a systematic review of 10 articles. And so, of course, that was higher deprivation index was associated with more readmissions and decreased 1-year survival for oncology patients. Where I really think we should try to transition our research over the next several years is work that like Teresa is doing and several of our other colleagues, where we focus on the individual interventions. We had a speaker yesterday talk about wearable technology. These are all ways that we could consider intervening on a more granular basis. Everybody that might have a high deprivation index might not experience the same challenges. There was a study that showed that patients who were from a socially disadvantaged area were still way more likely to present for follow-up if they had the opportunity to perform a telemedicine visit, versus 49% of them weren't able to make it to an in-person visit, which is kind of counterintuitive because these patients may not have access to the same technology in our minds that would enable them to do that or be as literate with technology. In general, they seem to be able to handle that challenge. And so when we think about what we have available as health systems, what we can advocate for payment for our patients and support from insurers, things like transportation, wearables at home to detect challenges that would maybe predispose to readmission, nutrition intervention, home health care access, meaning how many times is the wound nurse going to come and change their dressing per week? If you don't have a family member that can do that for you, maybe that's someone who we advocate for more than the standard number of visits that insurance would typically pay for. These are some ways that we can kind of use precision care rather than just precision implants to advocate for our patients. And so I just put this up there because, there are all these nice graphics that put out there the details of how, we would measure each of these impacts in the overall understanding of social determinants of health. But what does that really look like? Hey, you want me to get more x-rays? I just paid for x-rays. Why do I need another one this week? You're 2 hours behind. I got to get to my job. I'm going to lose it if I don't get there. Are we really lost to follow-up, or would a simple Lyft ride that's reimbursed by insurance get that patient there? So I think at this point, even though a couple of years ago there was an amalgam of papers over the years that had really not addressed social determinants of health, it is something that's captured frequently now, but I think it's something that we need to transition our research more into collecting prospectively and especially focusing on interventions. So hopefully I'll keep us on time. Thanks, guys.